Hello, I'm Dr. Ken Landau. Thank you for joining us. We're discussing atrial fibrillation, a condition that we said is extraordinarily common. It's common as we grow older. It's very uncommon in children. It's uncommon in people less than age 50, only about half of 1% of the population with the condition. But as we grow older, we find that the condition increases in prevalence, so that between 60 and 70 years of age, maybe as many as 4 or 5% of the population suffers with the condition. And then as we grow even older than age 80, the incidence increases to in excess of 10%, and it's estimated that a lifetime risk for atrial fibrillation in a person who's 40 years of age or more, well, it may well be as high as 25%, 1 person in 4. But not all people are at equal risk. Obviously, those people who have more cardiovascular problems, people who have more high blood pressure, people who've had heart attack, people who've had other sorts of problems with the heart, people who have some other kind of medical issue, chronic obstructive lung disease, obstructive sleep apnea, all of these conditions seem to stress the heart. People with congestive heart failure, 5 million people in that category in the United States, all of those people are at increased risk. But the question is why? Well, it's important to realize that when we talk about atrial fibrillation, we're talking about the top chambers of the heart. Okay, so remember, we have 4 chambers of the heart, 2 atria up on top, 2 ventricles down in the bottom. There's a junction between the two, and we call that the Atrioventricular Junction. That's where the electrical impulses go. Supposedly they start at the upper right-hand side in the sinoatrial node. They go down the atria, cause the atria to contract, go through the atrioventricular junction into the ventricles, and then cause the ventricles to contract. And they do that 60, 80, 90 times a minute under normal circumstances. But in atrial fibrillation, we have some kind of an abnormality of the atria. And it might be a variety of causes that lead to the condition. But there are all of a sudden an enormous number of impulses, as many as 300 or 400 impulses per minute, that are being generated in the top portion of the heart. Fortunately, they don't all go through to the bottom part of the heart, because we know that the bottom part of the heart can't go that fast. And if it were to go that fast, that would be ventricular fibrillation, tantamount to death. So let's look at what happens as blood goes through the heart. Blood goes from the right atrium, on the right-hand side, on the top right-hand side. The blood comes from the body in the inferior vena cava, the lower vena cava and the upper vena cava, superior or inferior vena cava, goes into the heart, goes through the right atria to the right ventricle, past the valve. When it goes into the right ventricle and the right ventricle contracts, then the blood goes to the lungs. It's unoxygenated blood, deoxygenated blood. Goes through the lungs, picks up the oxygen, goes back to the left side of the heart, the left atrium. There are 4 pulmonary veins, and those pulmonary veins carry the oxygenated blood back to the heart, gets to the heart, is pumped through the atria down into the left ventricle, the main pumping chamber of the heart, and then when the left ventricle contracts, the blood goes out into the aorta and goes to the rest of the body. It nourishes the brain, it nourishes the heart itself, it goes to the muscles, it goes to the stomach, it goes to the eyes, it goes everywhere. And then it returns to the left side of the heart. Okay? So the question is, where does atrial fibrillation originate? And there have been a variety of thoughts over the period of years, but in 1998 there was a seminal development when the group from Bordeaux discovered that in those pulmonary veins, there was actually somewhere between 1/2 inch to about 1.5 inches of atrial muscle cells, of heart muscle cells, that actually went into the vein. And it appears that those cells are sensitive to stretch, and those cells are what generate atrial fibrillation in the overwhelming majority of people early on. Now, over a period of time, we said that atrial fibrillation changed. It went from the periodic, or what we call the paroxysmal stage, into the persistent or the permanent stage. And as that happens, we know that there are certain changes in the area where the impulse seems to originate. But early on, it seems that it's these pulmonary veins and those myocytes, those cardiomyocytes, those cardiac muscle cells that go into the pulmonary veins by somewhere between 1 and 3 centimeters, ½ inch to 1.5 inches about. Well, it seems that those cells, because they seem to have ganglia. Remember, we keep going back to the story about the sympathetic and the parasympathetic nervous system, and we say that it's very important to realize that those particular cells, the cells of the nervous system, to a large degree control the heart muscle function. Well, we know that those cells in the, we call them ganglionic plexi, those cells that control the heartbeat go back up to the brain. And there's a significant interaction of those kinds of cells. So we have the muscle going into the veins, the heart muscle going into the veins, and we have the ganglia that are, at least in part, controlling the function of those particular cells. And then we have the stimulation of those cells in the nerve that lead to the fibrillation in those people who are so predisposed because they have some inflammatory problem, because they have some fat-related problem, fat where it's not supposed to be, and all of those things together seem to be what causes atrial fibrillation. So it's not just a simple matter of, hey, you got too much of the pumping of the top part of your heart. Well, we also know that over a period of time, it seems that the more we learn, the more sites seem to be potential generators of the impulses that lead to atrial fibrillation. So when we first discovered this, then people went right ahead and they said, well, look, what we can do is we can do this atrial ablation, and if we do atrial ablation, we just make little holes around those pulmonary veins, then we might be able to interrupt the problem. And that's done, and it's still done today, and it's done with some variable degree of success. But we now know that it's not nearly as successful as most people thought. Why? Well, because the cells that generate the abnormalities occur not just in the pulmonary veins, but they occur in the superior vena cava on the right-hand side, or they occur in what we call the crista terminalis, again on the right-hand side, or they occur on the left atrial muscle wall, or they occur in the coronary sinuses, or they occur in what we call the ligament of Marshall. All of those are also important areas, and they're not as readily amenable to simple ablation therapy. And you have to remember, so now we have muscles where they don't belong, we have nerves that are innervating them, we have an overactivity of the sympathetic nervous system that leads to stimulation of those cells and alters the likelihood of your developing atrial fibrillation. So now we have a condition where we have the genes that make a person susceptible, we have the autonomic nervous system, the sympathetic and parasympathetic nervous system. We have some flow-related issues. We have some endocrine-related issues with thyroid and some other hormones like renin and angiotensin. And then we have some exogenous factors like, are you a cigarette smoker? Do you have high blood pressure? We have the inflammatory mediators. So now all of those things seem to get together. And the bottom line is that when you have this condition, the more likely you are to have it, the more likely you are to get recurrent episodes. And once the person develops atrial fibrillation, whether you know it or not, because oftentimes it's going to be asymptomatic, you're going to have recurrent episodes. So what are the symptoms? What makes atrial fibrillation so important? Well, the symptoms are very variable. Some people have absolutely no symptoms. Some people don't have any symptoms at all. They have atrial fibrillation, they get back to normal, they go back to atrial fibrillation, they go back, don't have any symptoms, don't know when they have atrial fibrillation, don't know when they're normal. And as a matter of fact, some people have atrial fibrillation that's either persistent or permanent, and they still have no symptoms. Now, some people have hemodynamic consequences, because remember we said that the heart is a contractile organ. So everyone thinks of the contractions coming from the ventricles, those big, massive chambers in the bottom part of the heart, the part on the left that causes the blood to go into the aorta and then go to the brain and to the lungs and everywhere else, or the part on the right ventricle, that when it contracts, sends the blood lacking in oxygen into the lungs to not supply the lungs with oxygen, but to supply the blood with oxygen so it can go back to the left side, and then the left side of the heart is going to pump it to the lungs, into the vessels to actually perform the oxygenation, and in the brain and in the stomach and in the muscle and in everywhere else. So we know that if you have atrial fibrillation, the top part of your heart, the atrium, that normally contributes some degree of flow, maybe about 10% of the blood circulation is going to come from the contraction of the top part of the heart. Ain't going to do it. Ain't going to do it in atrial fibrillation. And as a matter of fact, as people get older, people become dependent on every little bit. Every little bit of oxygenated blood has to get pushed around. And if we don't have enough circulation, if we don't have enough volume circulating, then that's when you get the symptoms. You get the symptoms of congestive heart failure. You don't have enough oxygenated blood going around to the cells. You become fatigued. You have other kind of symptoms. So it's very important to have the top part of the heart, for many people, actively contracting. Now, if you're young and healthy, you might not need it, but as you're old and infirm, it might be very important. It's estimated that probably somewhere between 30-40% of people with atrial fibrillation are totally asymptomatic, and as a matter of fact, as people get older, there's probably a higher incidence of being asymptomatic. Well, some people, because some of those impulses are going from the top part to the bottom part through the Atrioventricular Junction, some people are going to have palpitations. They're going to have abnormalities in their heart. They're going to feel something is wrong, something is beating peculiarly. They're going to feel their pulses, and they're going to find the pulse is abnormal. And not only is it abnormal, it's abnormally abnormal. So it's not, there's no specific rhythm to the heartbeat, to the palpated heartbeat. Sometimes it's inappropriately fast, sometimes it's inappropriately slow. So what happens to our circulation? Well, we know if you have atrial fibrillation, you could have angina. Remember, atrial fibrillation, if you have a fast enough heartbeat, if you have a very fast heartbeat, well, the amount of time during the course of a minute when your heart is contracting is actually stiffening up. That's going to be increased. Well, if it's increased, when does the blood flow to the heart? When does the heart get its oxygenated blood? Because after all, everything needs oxygenated blood. Well, if you have atrial fibrillation with a fast rate, you're not going to get enough oxygenated blood going to the heart muscle itself, and then you could develop symptoms of angina, just like you would get if you had coronary artery disease. So sometimes angina isn't due to coronary artery disease, it's due to an abnormality of the heart rate. And that's important. And you could get pulmonary congestion. And you can have the palpitations that we talked about before. And then the question is, if you have atrial fibrillation and you have symptoms, are the symptoms from the disease itself, the atrial fibrillation, the abnormality of the heartbeat, or are the symptoms coming from too rapid a ventricular response? Because we know that if you have a rapid ventricular response, you're going to get more scar tissue forming in the heart, and that further leads to symptoms of heart failure or angina, or even symptoms of a heart attack. Or if you're not having normal contraction of the top part of the heart, and you're going to develop symptoms, are the symptoms from blood clots forming inside the top part of the heart. And if you develop some of the blood clots in the top part of the heart, and then they get separated off and travel through the circulation, they can go, certainly most notably, to the brain and lead to a stroke. Well, if you don't have enough pumping of the chambers because they're going too rapidly, you might have a lower blood pressure than normal. And if you have lower blood pressure, then you can have symptoms because of low blood pressure or dyspnea or pulmonary congestion because you're not getting the blood circulating through the lungs fast enough. And certainly if you don't have enough oxygenated blood, you can become fatigued and your exercise tolerance can become worse. And then we know that certain people, especially older people, can become dizzy. So some people just say, well, geez, I have these recurrent dizzy spells. I don't know why I have them. Well, it may well be because it's atrial fibrillation. But when you go to the doctor and you say, hey, I was dizzy last night, well, and the doctor does the electrocardiogram, doesn't find anything, because remember we said that in atrial fibrillation, oftentimes the symptoms or the condition is periodic. It comes and it goes. And we know that, as we mentioned before, in older people, as they transition from the atrial fibrillation back to normal, you'd think that's good. Well, it is good, except sometimes it confuses those cells at the atrioventricular junction, and now you have a drastic reduction in your heart rate, and then you can become lightheaded or faint. And then we know that if you have atrial fibrillation, other symptoms include symptoms of congestive heart failure and cardiovascular events. Cardiovascular events, heart attack, angina. So all of this can occur. And then we have the hemodynamic consequences. Remember we said the heart obviously is pumping oxygenated blood, and if it pumps oxygenated blood normally, then everything is copacetic. On the other hand, if it doesn't, just simply the rapid ventricular rate can cause problems. Rapid ventricular rate, again, seems to reduce the amount of oxygenated blood going to the heart, but also damages the heart by itself. And then we have people who have atrial fibrillation at the onset, right from the start. They can develop symptoms of left ventricular dysfunction. Left ventricular dysfunction. The heart isn't pumping enough oxygenated blood. That's when you get the congestive heart failure. Or it can be totally asymptomatic. And we know that the ventricular rate is going to vary with, among other things, that nervous system that we keep going back to, the autonomic nervous system, the sympathetic and the parasympathetic nerves that are at the ganglia right by the pulmonary veins, and they're extraordinarily important as far as the whole generation. So if you have atrial fibrillation, and it's important enough to be diagnosed, and you go to the doctor, and the doctor says, hey, you got atrial fibrillation, and he does that through simple testing, because after all, if you're in permanent or persistent atrial fibrillation, well, an electrocardiogram probably is going to make the diagnosis. It's when it comes and goes that we have the problem, and that may occur frequently. But if you have atrial fibrillation, the likelihood of dying within the first month is increased quite considerably, and then by a year, even greater likelihood of dying, and then by about 3 or 4 years. Now, not everybody has the same structural heart disease. So remember, the likelihood of dying isn't just because you have the atrial fibrillation. The likelihood of dying is because, number one, you have the arrhythmias, and they're caused by some sort of underlying heart disease, or number two, because you have a stroke. And that's the major issue with atrial fibrillation, is the stroke. But we know that the likelihood of death is greater in women than it is in men, and it seems that it's less as you grow older. Now, we know that even though people have adequate therapy, you go and you take your medicines, well, we know that even then, the symptoms tend to persist in probably about half of the people. So about half of the people are going to have palpitations. They take their blood pressure, they take their blood pulse, or they just feel that thumping in the chest. That leads to palpitations. They happen in about half of the people. And then we know that people are tired or fatigued, again, somewhere between maybe 15, 20%, up to 50% of the people with even treated atrial fibrillation going to have symptoms of fatigue or shortness of breath, again, somewhere between 25 and 50%, and angina, chest pain, maybe somewhere between 10 and 20%. Now we know that there's a pulse deficit, so we keep going back to the point of feeling your pulse. Well, if the doctor is listening to your chest and hearing what your heart is doing, and then feeling your pulse, oftentimes there's a deficit. And the rate that we find when we listen to the heart is greater than what we feel when we feel your pulse, because the heart doesn't have enough oxygenated blood. Maybe it's not contracting sufficiently, so it's not opening the valve, and the blood isn't circulating around. Now, we have another issue, and the issue has to do with stroke. Stroke is very common in people who have atrial fibrillation, and as a matter of fact, it is probably the leading cause of disability of atrial fibrillation. So we have a 50% increase in the risk of serious disability in people who have atrial fibrillation, and as a matter of fact, probably 25% of all strokes, especially in senior citizens, going to occur because of atrial fibrillation. Let me repeat that. Somewhere around 25%, or 1 in 4 strokes that are going to occur because of atrial fibrillation. So we have a significant problem, and those strokes can occur in people who are not known to have atrial fibrillation, because the atrial fibrillation, remember I said, can come and go, but once that clot forms inside your heart, the clot can stay there for about a month or so afterward before it gets to be organized or taken care of. So a significant problem with atrial fibrillation in people without any symptoms, and certainly people with symptoms too, is the ability to suffer a stroke, and that's why we talk so much about the anticoagulation. And as a matter of fact, the stroke might be the first evidence that the person has atrial fibrillation. The person might have thought that they were otherwise perfectly healthy. And not only can you have the major stroke, but remember, you can get little teeny-weeny pieces of the clot that form and are broken off and then go to somewhere else, like your brain. And those people, over a period of time, those multiple insults, not the one major massive stroke, but those little tiny pieces that get broken off from the heart and then spread to the brain, they can lead to what we call vascular dementia. Symptoms exactly the same as you would have with Alzheimer's disease. So seniors who are losing their intellect might not have Alzheimer's disease, they might have vascular dementia. And then we have the group in between, and we call that transient ischemic attacks. And transient ischemic attacks are in-between size clots breaking off from the heart and then going to the brain, and then causing what looks like a stroke, but the stroke seems to go away within less than 24 hours. So we have a variety of central nervous system complications related to the likelihood of atrial fibrillation. Now, the likelihood of stroke was about 48 in every 1,000 people over age 65 in around 1992. And that's about when the whole idea of, hey, we got to do something with this anticoagulation. We have the anticoagulants, we have the warfarin, Coumadin, and we might be able to reduce the incidence. And as a matter of fact, since anticoagulation has become much more prominently used in medicine, the likelihood of stroke in seniors fell from 48 per 1,000 down to only 17 per 1,000. That's about a 65% decrease. Now that's an amazing decrease. Well, even though we say it's 65%, remember, we're falling from 48 per 1,000 down to 17 per 1,000. So even though it's a 65% fall, the absolute decrease is only about 3%. But that's significant, because that's a lot fewer strokes. Now, there are two different kinds of strokes. One, because a person develops the blood clot that breaks off from somewhere and goes up to the brain. We call that an ischemic stroke. But then we have the kind where you bleed inside the brain. That's hemorrhagic stroke. It doesn't seem like the anticoagulation, the Coumadin, the warfarin, or any of the newer drugs reduce the likelihood of the hemorrhagic stroke. So remember, bottom line is that atrial fibrillation leads to more atrial fibrillation, and heart disease leads to atrial fibrillation. And what we need to do is we need to evaluate the people, find out what the risk is, and then decide what to do about it, realizing that dementia might be a symptom, realizing that stroke might be a symptom, realizing that shortness of breath or fatigue or easy fatigability might be a problem. Dementia, especially in elderly women, oftentimes unrecognized. Remembering that somewhere around half of all cardiogenic emboli actually originate from non-valvular atrial fibrillation. Now, this is an important concept. This is a new concept. So not only do the clots break off from the heart, get pushed out through the left ventricle, and then go up to the brain, but those clots can also go to the coronary arteries. So now we have a condition where the coronary arteries aren't getting enough oxygenated blood anyway because, one, the heart is spending too much time contracting, and the blood goes through the heart muscle itself, to the heart muscle itself, only during the relaxed stage. So now we have shorter relaxation stage, so we're not getting enough oxygenated blood in the first place. That's why some people who have atrial fibrillation are going to have the symptoms of angina. Sound like they have a heart attack, but they don't. But now we have blood clots that can break off from the heart itself and get into the coronary arteries. And a substantial number of people who have cardioembolic stroke seem to have a problem with heart attacks as well. And now we also know that just simply having a fast heart rate can impair the ability of the heart to function and can lead to susceptibility to atrial fibrillation and then to all of the problems that we're talking about. So hemodynamically, if we are not contracting the top part of the heart, we're not pushing in the extra amount of blood. Under normal circumstances, when the blood comes back to the heart, either from the lungs or from the body, it just rushes through the opening down into the bottom of the heart. But we need that extra 10% or so. Sometimes we have hemodynamic consequences because we just have a very rapid heart rate. Sometimes it's just a very irregular heart rate, and sometimes it's because we lose that synchrony between the top part of the heart and the bottom part of the heart, and that's very important. And then we know that atrial fibrillation obviously can cause the stroke. Obviously, it can cause, now we know, heart attacks. And now we're finding out some of those clots and some of the chemical abnormalities, some of the inflammatory, some of the hormonal changes can lead to a decrease in kidney function as well. And then we have all of the inflammatory changes. Now, it's important to realize that our medicines that we're using increasingly more often, those medicines like warfarin, Coumadin, can dramatically reduce the likelihood of stroke. And since stroke is such a major issue, that's something that we have to consider. So we think that stroke is maybe 12 million people with stroke every year in the United States, maybe somewhere around a quarter of them due to atrial fibrillation. We know that a lot of people are going to develop what we call a mini stroke, a stroke that seems to have symptoms that last for only 24 hours and then goes away within the 24-hour period, doesn't leave any kind of sequelae. We think that maybe as many as half of all people who suffer TIAs, transient ischemic attacks, mini strokes, suffer these as a result of the atrial fibrillation. And we think that probably if we look at people who are over age 75, probably somewhere around half of all strokes are related to atrial fibrillation. And remember, our paroxysmal atrial fibrillation oftentimes is totally asymptomatic. Don't know you have it. On the other hand, this subclinical atrial fibrillation can lead to a dramatic increase in the likelihood of stroke, an increase in the incidence from normal, say 1.5%, 2% per year, up to about 4 or 5%. Some people would say even greater. So we know that those strokes associated with atrial fibrillation tend to be worse than strokes not associated with atrial fibrillation. And we know that people who have atrial fibrillation and suffer a stroke are much more likely to suffer some significant disability or even die. And of course, we know that atrial fibrillation and the stroke related to the atrial fibrillation can be reduced in incidence by about 65%. On a relative basis. We know that's only about 3% on an absolute basis, but that's important. And we know the likelihood of death on a relative basis from atrial fibrillation and from stroke can be reduced by about 25% simply by taking a drug that prevents the coagulation process. So that's obviously very important. Now we have all sorts of drugs that can be used. And in the early days, it was thought that aspirin was probably as good as warfarin, Coumadin, in reducing the likelihood of stroke. But we know that that's probably not the case. And we know that depending on the circumstances, if you happen to have a stent put in your coronary artery because you have some narrowing of the artery and you have some symptoms, well, for those people, it seems that aspirin and another drug, a drug like Plavix or a drug like clopidogrel, those are going to decrease the likelihood of stenosis or a clot in the stent, but they don't do a very good job of preventing the clot in the heart from atrial fibrillation. So we have a secondary kind of problem. Now, let's say you've suffered from atrial fibrillation, and the question is, how long does the atrial fibrillation have to last before you're at increased likelihood of developing a clot inside your heart? And the answer is not very long at all. And as a matter of fact, we know that if you have atrial fibrillation for a period of, say, 6 minutes or more, 5 minutes or more, and some people would say for half a minute or more, then you have a greater incidence of developing a clot inside your heart, and then a greater likelihood that you're going to have a stroke. And as a matter of fact, we know that those people, especially those people who have enlarged left atria, and we can tell that simply on an echocardiogram, simple test, if the left atrium is larger than, say, about 4.5 or 5 centimeters, so about 2 inches, then that puts you at greater risk for a stroke. Now, a lot of tests are done with the transthoracic echo. In other words, they have a transducer, they put it on your chest, goes through your chest, that's transthoracic. Well, that's not nearly as good, not nearly as accurate as if we put the catheter right down your esophagus, get it really close to the heart, and then evaluate the heart that way. And when we do that, we find that even though the echo that the doctor performs in the office by putting the transducer on your chest, if that shows it's normal, that's not necessarily the case when the echocardiogram is done through the esophagus. So very important. And then we know, on top of everything else, not only is it the slow blood flow, but it seems that in people who have atrial fibrillation, there are other changes that occur inside the blood that make the blood more susceptible to clotting. So under normal circumstances, you have a fair amount of nitric oxide in your system. And then there's another chemical known as plasminogen activator inhibitor 1, and that's usually relatively low. But it seems that in atrial fibrillation, we have exactly the reverse. So we have more PAI1 and less of the nitric oxide. When we have less of the nitric oxide, we're more likely to have clotting. And not only are those chemicals, but we have thrombomodulin, we have something called VWF, von Willebrand's factor, and those factors also tend to make the blood more likely to clot. So that when we do studies on people who have what we call cryptogenic strokes, people who have strokes, we don't really know why they had the stroke. But among the other tests, we very carefully evaluate for atrial fibrillation. We evaluate what happens to the people over a period of minutes to hours to days to even months. We find that those people who have cryptogenic stroke much more likely to have atrial fibrillation, and then those people need appropriate blood thinners that if we simply did an electrocardiogram or a Holter test, we studied them for a short period of time, we wouldn't determine that they actually need the blood thinner. Obviously very important. Now, with all of this in mind, when we come back, we're going to talk about how we treat atrial fibrillation and how we prevent stroke. Thanks for watching, and come back again.